fever, rheumatic heart disease, as you know, is basically a disease of poverty. It's not a lucrative field to do research, do intervention. Of course, it has an important impact on the public health and basically affects the lower and middle income countries and people who have low human development index. If you see the distribution of burden of rheumatic fever, rheumatic heart disease globally, it is more prevalent in the lower and middle income countries like South Asians, African countries, South America, Pacific, the Pacific Islanders, those who are indigenous population in the Australia and the New Zealand. So, should I continue without seeing its slides? Kunal, how much time is it going to take?
It's actually excitement of I just forgot to upload the
I told you in the beginning.
It will be done in the next 2 minutes.
So basically, I will tell you before the slide gets ready. When we started this, the registry in our department, at that point of time, we really did not have any data related to demographic characteristics of the patients, clinical characteristics of the patients, what proportion of patients present in the tertiary care center with advanced complications, and what is the natural progression of rheumatic heart disease. And these were some of the areas where we did not have any information about our patient population. If you see the Indian scenario also, we do not have any data, longitudinal data of the patients with rheumatic heart disease, where we have followed the patients annually and assessed, recorded the clinical outcomes, like for example, the mortality because of the rheumatic heart disease and the incidence of various complications like atrial fibrillation, heart failure, strokes, and proportion of patients requiring interventions and the complication in the form of infective enterocolitis and the recurrence of rheumatic fever. So, and what happens to the progression of valvular disease? Basically, with passage of time, what proportion of patients show progression of the disease, what proportion of patients show regression of the disease. These were some of the important the information which were lacking. And so with this in mind, we had started our registry, which I'm going to share.
Stabilized, we might like to start initiate statin. Once there is modified risk factors like hypertension, etc. control. For prior ICS patients, again there is no harm in taking statins. Except for lobar hemorrhage patients or lacunar strokes, there are 2 areas where you have to be careful. So these are the various goals for excluding this category group A, B, where I think repeatedly we have been telling that goals should be less than 50 and 30. And this is similar to the general categorization. And there are the various goals. You always start with high intensity statin, then add SSRI, and then add PCSK9 because at that time of the publication of the guidelines, Delphodilix and GLP-1 didn't have any data. Subsequently, we had Delphodilic acid and the clear outcome data where it is shown that it reduces MACE events. So you can add Delphodilic acid once your goals are not reached. And then there is the SIR therapy. Again, increases the oil type in the level transgender, it does reduce stroke. And lastly, if in the reduced trial also there was reduction in stroke with 50% time, and not only first events, different stroke events also reduced. So the idea is simple: calculate your risk category, calculate your goal, and these are the expected goals which the expected reduction in LDL which will achieve in various death therapies. So you should go to the LAI recommendation, which you in lower income countries. Primary prevention studies have clearly shown that stroke reduction is almost proportional to MI, slightly lesser. Aggressive LDL lowering with high intensity statin is important for primary prevention and secondary prevention, so there is marked lead to stroke. Very low LDL levels are not associated with ICS risk. We have clearly seen almost 50,000 patients data from the improved IT 4A and ODC. Even the acute ischemic stroke after thrombolysis or before thrombolysis, we can initiate statin. In ICS patients, first the patient is stabilized, and then before discharge, calculated is a single category and giving statins. Lobar average